Good morning, everyone.
Good morning. This is Nicole Davis.
Hi, Nicole. I'm glad you piped up. I am having some issues this morning accessing my email, so I'm going to need you to share your own screen for your presentation. Is that okay?
Oh, that works. That works. I can do that.
Okay. And Nicolay Fogarty, if you're already on the call, same for you. Sorry.
No problem. I'll go ahead and do that.
Okay, great. We'll get started in just a minute. We still have some folks popping in. Elizabeth, that would be great. Thank you. Okay. Can everyone still see my screen okay? Okay. And
Yes.
Yes.
slideshow view. Okay, thank you. It gets a little wacky when you've got 3 monitors going. Okay, get started in just a minute. Still have folks coming in. Okay, I think we're good to get going. Good morning, everyone, and welcome to AHP Practice Managers meeting. Sadly, another remote occasion, and I look forward to the time when we can all be in the room together. But hopefully, you'll get some good information out of this morning's meeting. I want to run through the agenda really quickly. We're going to do some welcome and introductions. Hello, welcome. We're going to talk about some updates to the AHP team. I want to quickly go over 2020 gain sharing. That has already been paid out, but want to make sure everyone's aware of that methodology, so you understand that payment. We're going to talk about the Medline Pro Vista opportunity more in the context of what we're calling GPO 101, explaining this very complicated business to help give you a little more context to understand the value of this opportunity. Nicolay Fogarty is here from Vatica to talk about the HCC program, which has some really robust incentives for providers. Christy Howard's going to review our new provider engagement report. We have new screenshots to share with you. We'd like your feedback on. And Willie's going to talk about Arcadia with some follow-up to the survey that many of you participated in and give you an update on the most recent upgrade. Elizabeth Sharp has returned from her maternity leave, and she's here to talk about the hypertension toolkit, give you a little preview of that, quickly talk about COVID resources, and then our primary care practice champion pilot. So for those of you who are joining us who are from a specialty practice, who are not in primary care, we really kind of front loaded the agenda for you. So probably anything after the Medline presentation wouldn't apply to you, and you'd be welcome to leave the call, obviously, if you care to. So just wanted to make you aware of that agenda for the specialty practices. So we'll move right into our welcome to our new attendees. I'm pretty sure all of these folks are on the call. Hopefully they are. Janice Namorato is practice manager at Greece Pediatric Medicine. This is a new practice started by Dr. Wania. Chelsea Yeager from the Gastro Group of Rochester, their new practice manager. Jennifer Radigan is a quality staffer over at Oak Orchard, and she's joining the group. And Tammy Chris from St. James Primary Care are all new folks to this group. So welcome, and we hope you get good information. And please, we keep this meeting really casual. And if you have any questions, just pop it in the chat or raise your hand. We're glad you're joining us this morning. We're going to move on to our staff updates, just a couple of quick ones. We have two new care managers joining the team. Robin Shep is a pediatric social work care manager, and Kim McGregor is an RN care manager. I know that Kim McGregor is down at Cayuga Family Practice. Robin, I'm sorry, I don't recall which practices she is supporting. I had that in my a document that I can't access this morning due to my technical issues. So I apologize for that, but welcome Robin and Kim, and we're glad to have them join our care management team. And then we also want to make sure that everyone's aware of some team members on the move. Our former PR liaison, Kevin Kelly, who was part of my team, is now the project manager for business operations working for Kim Povak. I couldn't remember if we had made that announcement to this group or not, but wanted to make you aware. So if you have any provider relations business that you would normally have gone to Kevin for, please contact me and I can assist you. But Kevin's still part of the AHP team, for which we're really grateful, and know he's doing a great job with his new responsibilities, working with Kim and Chad Teeters, our medical director. So with that, I'm going to jump into just 2020 gain sharing. The purpose of this, just to make sure everyone understands how these payments were made, because this was a complicated year for gain sharing. There were a lot of moving parts to this performance year gain sharing. And then of course, just that reminder I always do of what is gain sharing, how do we earn gain sharing? We earn gain sharing when we beat the budget and we hit our quality measures. So it's the good work of our PCPs meeting those quality measures. It's the good work of everyone doing what they can to deliver well-coordinated patient-centered care that reduces costs and increases the value of care. Those are all the things that result in us earning gain sharing. Now, 2020, as we all have lived through, was an exceptional year and resulted in an unprecedented number of gain sharing, amount of gain sharing, due of course to the fact that people weren't going to the doctor and obtaining care, which we understand had quite a negative impact on so many of our practices, that loss of volume. But that loss of volume translated into us beating our budgets under our contracts by a great deal. So because of that, and because of our ability to see that coming in 2020, the payers advanced us some of what we expected to earn for 2020 gain sharing. And we paid out to you that advance in December 2020, and we just mirrored what we had paid to you in 2019. So everyone received a payment, all the PCPs that were participating on all contracts received a payment in December that was an advance on their 2020 gain sharing. And that was paid out according to the 2019 methodology, which was a base and a number of attributed lives and quality. So for that 2020 advance that you received in December 2020, PCPs on all contracts got a $2,100 base. They got $3.95 per active patient on their panel. And then for quality, it was based on their performance. Did they rank in quality at the gold, silver, bronze level? So this was the 2019 methodology that we used to make the 2020 advance payment. Now, fast forward to, I'm sorry, I'm distracted, guys. I'm hosting this meeting alone. I'm still letting people in. So I'm sorry if I'm all over the place here. So fast forward, now we have our full amount of 2020 gain sharing has been paid out to us. And we recently paid you the balance of what we owed you for 2020 gain sharing. We just made that payment early in August. So this methodology was, come on, wake up here. Same methodology in terms of base, lives, and quality, but PCPs received a $4,600 base. They received $7.80 per active patient on their panel. And then their quality award, whether they got gold, silver, or bronze, were in these amounts: $10,200, $8,500, or $5,100. So altogether, when you add up the advance that we paid in December and then the balance payment that we paid in August, the average adult PCP earned about $22,000 total for 2020 gain sharing. And that is about double the amount historically that an adult PCP has earned for gain sharing. Peds earned Peds earned about the same. There's a big variation there for pediatrics. They generally have bigger patient panels than the adult providers do, but many of them also aren't full-time, full FTEs. So, I think it's fair to say about the same. I would say your average PCP earned about $22,000 in gain sharing. For the specialists on the call, you got an advance in December of around $1,200. And then we gave you a balance recently of $1,300 per provider. And that went out just a couple of weeks ago for our specialty practices. I'm going to take a breath and ask if there are any questions about gain sharing. And I can't see hands, so just pipe up or pop it in the chat. No? Okay. Well, then I'm going to stop sharing my screen and introduce Nicole Davis from Provista / Vizient and Jennifer Taskin from Medline to do a brief presentation about their work and how GPOs work, and just want to give you a quick primer on that information to help you understand the value of this Medline Provista opportunity, in which AHP participating practices, primary care and specialty, can access the same pricing that URMC gets on medical and other supplies for your practice. That same pricing, and it's very advantageous. So I'll turn it over. I'll stop my share, let Nicole and Jennifer share their screen, and I'll turn it over to you guys.
Okay. Good morning, everyone. This is Nicole Davis with Vizient Non-Acute / Provista. I'm trying to share my screen. Hold on. It's just flashing. Let's try this again. Is everyone, I guess, Renee, are you able to see my PowerPoint?
I can see your PowerPoint, but it's not in slideshow view.
Okay.
Which is fine. There you go. Now you're in slideshow view. Okay.
Perfect. Okay, great. So good morning, everyone. Thank you for the opportunity for allowing us to speak to you. This is Nicole Davis with Vizient Non-Acute Provista. And then I'll go ahead, and I believe Jennifer is on, but I don't believe Tom is. So I'll let Jennifer go ahead and introduce herself, and then we'll get started. You may be on mute, Jennifer. Jennifer, I don't think we can hear you. Can anyone else hear Jennifer, or is it just, okay.
Oh, why don't you just get started, Nicole?
Okay, yeah, if anything, she can pop back in. All right, let me see if I can switch these slides. Okay, there we go. Okay, so as most of you probably have seen, I know we've sent out a couple of newsletters and documentation. We did develop a program, an aggregated program for AHP, and Provista partnered with Medline for this program. And this is just the flyer that we were able to send out, but I'm going to kind of go into a little bit of what a GPO is, because I know many of you are aware of what Medline is, but you might not be aware of the advantages of being part of a group purchase organization. So I'm just going to go over to the next slide. And I apologize if this seems pretty entry level, but I wanted to make sure that we're covering the basis. And I know some of you may be more familiar than the others, but I wanted to kind of just go to a granular level. So what is a GPO? A GPO is a group purchasing organization that leverages the purchasing power of all of its members. And then with that power of aggregated spend, the GPO has a better position to negotiate pricing and also some other special pricing for group buys and other promotional things that we're able to reduce the pricing of many of the national products that you may use, whether it's medical supplies, pharmacy, purchase services, such as like FedEx, Iron Mountain. Those things we all negotiate with the supplier for. And we are powered by Vizient. Vizient is the main company, and then we have multiple divisions within Vizient. So Provista is really the non-acute division of Vizient. But I wanted to point out that as a collective Vizient membership, we have
Can everybody hear me now?
There you go. Perfect.
Okay.
I'll give you these 2 slides.
Thank you. Sorry, I was not able to do the introduction. For some reason, the volume just didn't work. So I logged out and logged back in. So now we're good. Hi, everybody. I'm Jennifer Taskin with Medline. I am the district sales manager and I cover Rochester, Albany, Syracuse, and Buffalo. And I have reps in each one of those cities to support anybody that is in and around those areas. So just a quick overview of Medline and who we are. Medline is a manufacturer as well as a distributor of medical supplies and capital equipment. So what that means to you is the national brand items that you buy, the BDs, the Welch Allens, the Midmarks, the 3Ms, you can buy from Medline just as if you're currently buying today. And then the additional piece is that Medline manufactures our own products as well. So things like toilet paper, paper towel, point of care testing, almost anything inside of your office. I like to joke with offices and say we sell everything except for carpeting and paint within your office. Medline, we have been privately held. We just recently had a nice offering that Medline thought would really benefit our portfolio. So we've aligned ourselves in a position where we think we can better service all parts of the world. Medline is all over the world. We are not just in the United States. We service the entire continuum of care. We basically service a patient from diaper to diaper. So we take care of pediatric offices, primary care offices, specialty offices. We're in the acute care space. And we are also in long-term care facilities as well. We have 2 warehouses in Rochester. We have 1 in Brockport. We also have a second warehouse in Canandaigua. And then our main hub is in Middletown. We do next day shipping. So if you place an order today by 1 p.m., you will receive your stock supplies the following day. We do free shipping over orders that are $150. We do for offices that do come on to Medline. We, for the first 3 months, offer no shipping charges at all. We feel that, we want you to get used to Medline, get used to ordering. Sometimes you forget things and you want to just order, 1 or 2 items and those 2 items could cost $5. So we want you to get used to that. So for the first 3 months, there is no minimum order that you need to place with us. Anything over $150, there is no charge, no freight charges. We have a lot of different options available in medline.com. So things like setting up shopping lists off of what you're currently buying from another supplier. I like to cross and then put it into a shopping list, so it's very easy for you. We have different resources too on medline.com. So we can set up things like formularies. We can set up rules. So maybe you want, somebody to be able to place an order, but you want to have eyes on it and approve it before the order goes out. We can set up different things like that. We offer LUM for everything. So everything is available to you if you want it in the lowest unit of measure. We do white glove installation for, any type of capital projects that you might have. We have a company that we use where all the orders that you have for any type of capital project would ship right there. Then they would call and coordinate with you and me when to deliver the products. They would come, they would set up, they would take down, they would bring all the debris out. So they're a great company that we use. We have a local dedicated team to you. So you have myself, the sales rep, and then you also have your local, what we call a dedicated service rep. And the dedicated service rep would take care of just the AHP accounts. So when you're inside medline.com, if you have a question, you're looking up, something and you can't find it, we want you to be able to call your dedicated customer service rep directly, and she will be able to help you any types of returns, or every once in a while, if you have a mispick inside your box, she would be able to handle for you. We do lots of sequestering. We do lots of sequestering for A1Cs, pregnancy tests, and anything that you would need to be that would be lot sequestered, we offer for you as well. We do have, once an account is fully set up and fully connected to Provista, we do offer price parity and transparency. So any type of price changes, so let's say pharmaceutical changes, we all know that that pricing can change a couple times throughout the year. We get 60 days notice from most vendors. So we would communicate that to you. The pricing would be aligned across all HP accounts. So if you're paying, $10 for a box of syringes, let's say the 3cc syringes, and you happen to be having lunch with Jim at another practice, and Jim says, "Oh, I'm so happy I got $5 a box of those syringes from Medline," you would say, "That's great. I'm paying the same too. One's not paying $2 and the other one's not paying $10. So we think that is nice for all the offices. We do have a pretty seamless implementation. I do a cross of what you're currently buying. Then I do an analysis for you. And then from there, we look at how you want to order, any type of assessments logistically that you want us to review with you at your office. Can we make it easier for you to order in a ship schedule so you have less boxes in your office, or any type of things for revenue generated opportunities? So we have a lab specialist who would come in and sit down with you, and he would review with you what you're currently doing in office, what you're sending out, what maybe you can bring back into office to hopefully generate some revenue for the office. And then the last thing that we have is we have the support. So I can come and see you weekly. I can see you monthly, however you want to do it. But we have a lot of reports, and we have a lot of things that we can offer that I think sets us apart. So, anytime you want to look at, things that you bought last year that maybe you might want to look for an opportunity on savings on, or if you want samples, so anything Medline branded, we would love to send you samples on so that you can try before you buy, instead of, buying a box, not liking that and looking to, maybe look at maybe a different type of gauze. And then we send that out, and then, does the providers or does the nurses like that? So any type of samples that we can send, we love to send samples. You try, we do a switch, we show you a savings. And then lastly, the thing that I want to get across to the practice managers here is it's not an all or nothing with Medline. We just want to earn your business. So if we earn your business by you buying just gloves from Medline branded gloves, we would love to do that. I don't want anybody to think that you have to switch all of your supplies. I mean, I know that being in the business for a long time, you get used to your rep, you develop a relationship with them. And I respect that because I'm a rep too. Even if I did a cost analysis for you and your top 5 that was, a 20 or 25% savings that you thought, geez, this is just, a great savings. I really don't want to pass that up. You can buy those 5 items from Medline, and maybe down the road, 5 items will turn into 10, or maybe it'll stay at 5. And any of that is okay with Medline. So I just wanted to make sure that everybody knows that it's not an all or nothing with us. And that's really it for just a quick Medline overview. Thank you.
You're welcome. Let me just try to, there we go. And what I did here was I kind of put in a general contract implementation in action. And the reason being is because, there are steps to get access to this pricing. So, once you become a member, we analyze your data, right? This is where Jennifer is looking at your product, seeing where there's the top savings, what can we do to maybe possibly look at some conversion opportunities if the savings is there. And then we want to start with membership enrollment. So when you're enrolled with Provista, you are generated a member ID, which is basically like a ship to account number for Distribution World. And that MID is assigned to your facility. Once we have that MID in place, we're leveraging PureNet. And let me just kind of clarify what PureNet is. Provista purchased a procurement company a few years ago, and that company was PureNet. And what that is, it's a team of people who actually request connection to those contracts for your individual facility, work with the suppliers to get approvals. And if there are denials, then what is the reason for that denial? In instance, there's a handful of suppliers that are a little bit more challenging to get connected to, right? So let's just use Johnson & Johnson as an example. We have a couple of Johnson & Johnson contracts. If you connect to the contracts, you'll get, let's just say, an average of 25% savings. We request access to that pricing for your facility MID, and then Johnson & Johnson sends a denial saying that you can't access that contract. Well, what is the reason? And the reason is that you don't have a Johnson & Johnson account number set up for your facility. And it's as simple as that. So now we just the PureNet team works to get your documentation, whether it's setting up account numbers or just giving additional shipping information, to make sure that you're getting access to that contract. So the reason why I put this here is because there are a lot of steps that our team is putting in place to make sure you get this pricing, but this pricing isn't automatically turned on when that MID is generated, right? So it does take time to get those supplier approvals. You are eligible to access a lot of these tiers through the PureNet aggregation program, right? But there are some contracts that may be approved in a couple of weeks, and then there are maybe some contracts that maybe take 30 to 60 days to get approved. And the reason being is because we're dependent on the supplier to approve the price. So yes, the contract does exist. You most likely will get access. I can't say 100% all the time because it's up to the supplier to approve that pricing. And then once that pricing is approved, then we work with Medline to make sure that they have the approvals and the documentation they need to load that pricing and turn on that pricing for your center. Once that pricing's in place, then we shouldn't have any issues moving forward. I know Jennifer is doing an absolute fabulous job just auditing your orders and making sure you're getting the correct price. If there's any issues, then correcting those immediately. There is a little bit of a transition standpoint when it comes to onboarding with a GPO, just because of those contract connections and supplier approvals that we require. But once we have those in place, it should be pretty smooth sailing. And then again, that PureNet team is the one who's working with your suppliers, working on your behalf to get access to that pricing, and then continuously monitoring that pricing on a monthly basis. So if we see something that maybe was shipped that wasn't on contract price, then that PureNet team is going back and saying, why isn't that price loaded? Whether it's something that, distribution Medline has to work on, or whether it's something that the supplier hadn't approved, and then we just need to get those ducks in a row so we make sure that you get the pricing moving forward. Okay. And I know that was a lot of information, but I definitely did send this presentation to Renee. So if any of you wanted to kind of look over in a little bit more detail, you have time. But also, I am a resource for you. So if you have any questions as it relates to GPO or anything maybe outside of distribution, then I can definitely support you in those questions. What I did here was I provided a snapshot of our purchase services. So these are typically products that wouldn't funnel through Medline. Like an example, FedEx, and then Xerox is a big one. So these are just our top suppliers for purchase services, and breaks it down by category level. So you'll see environmental services and telecom. I can send this document to Renee as well to distribute to the team. I believe it's actually a 2-page document, but I wanted to provide you with a screenshot that you can kind of get a glance at it. And then in addition to, not only does your facility get discounts, you as an individual get discounts. So I always love this slide because I think a lot of times, we're so inundated in our job and looking at savings, and we want to make sure the facility gets savings, but you also can get savings for personal use as well. I use this all the time as a Provista employee. I have access to the savings, but simple things like going to the movies. I downloaded this savings app, and it's a separate app from Vizient or Provista, and you use your username, you sign in with your email address from your facility, so your AHP or whatever that facility address is, and then you're automatically enrolled in these personal savings. So you can get savings on Sherman's Williams. Like I said, I go to the movies. I buy movie tickets before COVID, I used to go with a group of people. I would buy the tickets for everyone and save $5 on each individual ticket. So because I purchased the ticket for the group, everyone was able to get those savings. So it's really a great benefit to have. And I think a lot of people forget that we offer employee discounts as well, but you are able to get these discounts. So if you ever have any questions, I can also send this flyer to Renee, which gives you instructions on how to sign up. But there's pretty significant savings that you can get on a personal level as well. So I wanted to highlight that because there's no commitment here. Once you become a member of Provista, it would be Provista, then you have access to these personal savings. You don't have to spend a certain amount of money. You don't have to sign up for any contracts. Once your MID is generated, you have access to this. So I thought this was a nice way to end the conversation because, it not only benefits your facility, it can also benefit you as an individual. So, and I think that's all I had. Yep. And my email's at the bottom. Not sure if we have any time for questions and answers, Renee, but I'm sure happy to answer any questions. I know Jennifer's on the line as well.
Thank you, Nicole and Jennifer. Does anyone have any questions? You throw them in the chat or pipe up. Okay. Well, we appreciate your presentation today. AHP is bringing this program to you because we think it's a financial benefit to practices. I appreciate Jennifer's comments. It's not an all or nothing. Move some piece of business over that makes the most sense for you and see how it goes. AHP has no skin in this game. There's no financial benefit to AHP, whether you join or you don't, or you move business over, or how much you move. We really are just as aggressively marketing this to you because we care about your financial position and your private practices and think this is would be a benefit. So please feel free to reach out to me if you need more information about this opportunity. So with that, I would like to, I'm sorry,
I'm gonna
Nicole.
jump off, Renee. Is it okay if I jump off? Okay,
Of course.
perfect.
Okay.
Have a great day, everyone. Thank you.
Bye, everybody. Thank you very much.
Bye, guys. So I'd like to introduce Nicolay Fogarty, who is from Vatica. And Vatica is a program that many of our primary care providers, adult primary care providers, are participating in, but there is an opportunity for many more who still haven't engaged with Vatica. And this is a program that AHP is encouraging because it assists AHP with our performance in some of our contracts, specifically our Medicare Advantage contracts, which I won't get too deep into the weeds, But essentially, what the Vatica program does is providers who participate are going through coding exercises in order to ensure that the correct level of acuity to a given patient is assigned. And what that ends up doing, where every possible condition has been accounted for a Medicare Advantage patient, is that in turn, CMS pays their Medicare Advantage payer, let's say Excellus, more for their care. And when an AHP is in what is called a percent of premium contract, the more Excellus makes on its Medicare Advantage patients, the more AHP stands to gain in gain sharing, and therefore the more you stand to gain in gain sharing. And this is all by way of doing, closing gaps in care and identifying complex conditions in patients and documenting them in such a way that Excellus can make the case to CMS that the patient's acuity level is entitled to a higher level of reimbursement. So that was a real ham-handed introduction to it. I'm a little out of practice. We haven't talked Vatica in a long time. So I will turn it over to Nicolay to do a better job explaining it to you. And what she's also going to do is talk about what are some very robust financial incentives for providers who do this. So Nicolay, take it away.
So much, Renee. I'm going to go ahead and see if it'll let me share my screen here. See if this works. Let me know when it's up. Can everybody see the screen?
We can see it, but it's not in slideshow view.
Did it switch?
Now it is. There you go.
Excellent. Okay, thank you again for your time this morning. My name is Nicolay Fogarty, and I'm the Director of Provider Engagement for Vatica Health. And today I'm just going to give you just a brief overview of what provider engagement is and a high level of the benefits and services that Vatica has to offer. I know we have kind of a mixed audience this morning. Many of you are already participating in the program, and then we also have some who are not yet participating. So we'd love, to have you have some awareness of this and get you going. The best practices that we're seeing to promote success, I'd like to dive into, because of those groups that have been working with us for a while, it's nice to see what we've learned from practice managers just like you. We are going to talk about the financial opportunity here and leave some time for answering of any questions. So provider engagement, this is the team members that are currently representing the broader markets that each of the offices within AHP reside. So we have Adam Stopa, Michelle Manabianco, and Heidi Pierce. So you'll hear their names, they'll be reaching out to you. And what they do is they really work with each office one-on-one to discover any barriers or issues that you have that they can help you with, and really promote optimizing performance within the program. And they do this by going over analytics with you so you can see how many members are eligible for each provider, how many they've signed off on, and make sure that they're on that trajectory for their full potential for the year. So what is Vatica Health? Vatica Health is a quality and risk adjustment program, and we were founded back in 2011. We had a very unique model because we would take clinical teams and we would pair it with our user-friendly technology and really help practices in this transition to value-based care and success within those models. We see a drive in utilization of preventative services such as vaccinations, enhance quality of care because we're able to help the providers understand where there's potential gaps in care, such as mammograms, colonoscopies, improve financial performance, which we will dive into a little bit further on in the presentation, but the program does come with a nice incentive from our health plan sponsors and can also contribute to gain share arrangements. So what are we doing that in the program itself? So we're removing the administrative burden from practices by having our clinical teams do a really rich deep dive into the patient's record. They receive information from the health plan sponsors in advance, and then they surface up chronic conditions for your providers to either accept or reject. And what we're ultimately doing is streamlining that documentation and coding process so that it meets CMS guidelines. So why is risk adjustment so important? Well, it's really to improve the care of patients. And ultimately, as we become more accurate in the coding, as Renee was explaining, CMS sees that full burden of illness for those patients and can properly ensure that the funds are there to care for them as they age. This discourages health plans from selectively choosing healthier members that they would have thought would have reduced their costs, because now we're ensuring that the funds are there for the patients that, need greater attention. So one of the things that I like to mention is that per CMS rules for risk adjustment, 85% of the funds that are earned from risk adjustment need to be reinvested into member benefits across the population. So this really allows patients to have a broader selection of plans, access to specialty programs like Silver Sneakers and transportation benefits. We see better outcomes in early detection from the work that the providers are doing, as well as improved compliance. There's studies that show patients that suffer from obesity, the more that they come in and see their provider, the greater chance that they have of overcoming that and really showing signs of improvement because of their engagement and the own management of their care. So what is in the value proposition here for the clinicians? Well, the goal of any risk adjustment program is really to reward the providers, the clinicians, for actively reaching out to patients and proactively engaging them in their care. We see a better understanding of that full burden of health, which increases and improves the overall outcomes. We see reduced submissions and chart reviews. As we begin to document more accurately on the front end, there's far less audits that you see from health plan partners after the claims have been submitted. There's an improved performance in value-based care arrangements, since we're working to try and ensure that those gaps are closed and we're checking off all those boxes. And the financial benefit is significant, because as you improve your performance, it really helps you in other revenue generating programs that you're in, such as gain share arrangements, STAR and HEDIS. So what I have here is a case study that Vatica did to show you guys the impact that Vatica specifically is having on quality and risk adjustment with the people that we work with. So this was a case study that was done with one of our health plan partners, and it was done on over 20,000 patients. And what they did is they took a look at all of these measures for those who went through Vatica Health's process in comparison to other quality and risk adjustment programs out there. And those other programs ranged from, new features inside EMRs to vendors similar to us that will come into the offices. And as you can see, Vatica out-surpassed the competitors in every single category. And some significant, closure of these tests and therapies, especially osteoporosis management and, diabetes, hemoglobin A1C. So it's really nice to be able to see the direct correlation to the quality of care when you participate in the program. Now, this next slide talks about the HCC prevalence. And this has a very strong and direct correlation to, RAF scores. And as you look at this, we take a look at these top 7 chronic conditions. And in each of these categories, once you're working with Vatica, we see an aggregate average increase of 35% of accurate coding in these categories. So let's take a look at this diabetes, with complications here and what this looks like. So in the blue, you're seeing the amount of codes that were done without complications. And when being reviewed by a Vatica staff member, these are then actually shifted into this chronic conditions with complications category. And more than half of the volume of what was coded before really belonged in that bucket. So as we become more accurate in our coding, we do see a significant impact on our RAF scores. And as Renee mentioned earlier, that can have a very significant impact on gain share arrangements. So how do we optimize performance in this program for people that are already in it? What are some tips and tricks that we've found as we continue to advance and grow? Vatica is a very PCP-centric organization, and we value the feedback that comes in from offices, and we learn from that, and we advance and offer, a different range of services, and try and really help practices optimize their performance. Some of the things that we see make a huge impact is ensuring that practices are scheduling from the Vatica Health roster. This is a list of all the eligible members by the health plan for the program. And as you use that list and call those patients and bring them in for your appointments, we see far greater, penetration overall. Connecting to all approved visit types. So most of our health plan partners allow us to connect this VATICA process to annual wellness visits, but also to 3 to 6 month follow-ups, preventative visits, transition of care visits, even telehealth now since COVID has, come and settled in here. And we can see that we can have a much greater impact on helping you guys attain those goals, reach those incentives when you take full use of all the benefits of the program. And the next thing that I have here is utilizing advanced practice providers. Not all nurse practitioners have their own patient panel, but they do have the ability to sign off on the VATICA process. So the person who completes the VATICA process is the one who's done that face-to-face or telehealth encounter with the patient. And there's a lot of things that you can do to help, providers that are struggling with time by utilizing those APPs to the fullest. And we can dive into greater detail with each individual practice we work with through each of these, benefits that we're talking about and tips and tricks to ensure that they fit your specific workflows in your practice. The next thing you see on the list here is provider education. And this actually has a very significant impact. So very much to what I just went through explaining why risk adjustment is so important, helping with the care of the patients overall and the impact specifically that VATICA is having, as you saw, with closing those gaps, having those tests and therapies, but also improving the accuracy of coding. We outsurpassed all of the competitors in the case studies. So ensuring that the providers really understand why you have chosen as a practice to participate in the program helps them to succeed, because then they share that same value and mission that you have. On the right side here, this dives into a little bit more specific on what we can do to really increase that clinician participation. Assigning a program champion. Oftentimes we'll see medical directors or lead physicians being the ones who will step into this role. And it's helpful because they really kind of champion the program. They help the other physicians understand the ease of use in the technology and why it's so important. When they see one of their fellow, teammates championing this and doing it, they think, well, if they're doing it, it's not that hard. I can do this too, and we can all make a difference. Setting clear expectations around participation. And what I'm talking about here is the signing of the VATICA record. So each provider has 60 days from the date of service to complete this work. And on average, it takes around 5 minutes per patient. There are things that we can do to reduce that time with providers as well. And it's really making sure that they understand why they're doing this so that they have that sense of accountability and ensure the records are signed. If they do lock, then everybody loses that rich information that we're collecting that really helps improve those scores. And the third thing that I have on the list here is the incentives. So the health plan partners that we work with are supplying an incentive for participation in the program. They did this really because they want to encourage the providers to hit the highest level of penetration that they can, so we can really have that accuracy in coding and improve the care to the patients. So we see in many cases, there are people who don't pass that incentive down, but the ones who even pass a portion of that incentive down to the person who's physically doing the work, we see much higher levels of success in the program. The next slide here is going to talk about the health plan partners that we're currently working with in your area and dives in a little bit more into this financial opportunity. Now, as you can see here, we are currently working with Excellis, Health Now of Western New York, Humana, MVP, Univera, and WellCare. We do have other health plan partners that we're working with as well, and some other national organizations that we're close to contracting with that I'll be excited to share once everything is finalized. As you can see, we are participating with them all on the Medicare Advantage line of business, but in some of the health plan partners that are sponsoring our program, they've actually expanded because they're seeing such a rich benefit from what is being done. So they've expanded into commercial and in some cases, even the Medicaid population. So what happens in the program is you are able to have that billable office visit, and we see increased comprehensive visit rates because people are utilizing that VATICA roster and seeing all those eligible members that need to be brought in, who may have otherwise gone without an appointment in the calendar year. Those visits generally range around $140 for that claim that you submit to your health plans. So you receive those funds. And in addition to it, the health plan partners provide an incentive for them e-signing in the Vatica, tool. And that incentive ranges from $150 to $175 per patient record that's signed. So just as an example that we have here off on the side, let's say somebody had 400 eligible members and they were only able to complete 75% of those visits. That still translates to over $45,000 in additional revenue that goes directly to your practice for participating in the program. In addition to that, as Renee's mentioned and I have as well, is you improve that accuracy in coding and HEDIS accuracy. It increases benchmarks and accuracy and outcomes. So it really does have a significant impact on gain share arrangements. This next slide is going to dive into an even extra benefit that you have with Excellis. And I would say that is courtesy of AHP. Because you are a member of AHP, Excellis is actually going to reimburse you at $175 for every time that you complete this Vatica process on a patient. In addition to that, because they want to reward those who are, strong performers in the program, once a clinician hits 65% penetration in their eligible members in that line of business, they'll receive an additional $50 for every patient that they've completed. So let's say they had a 100 patient panel. Once they complete 65 of those patients, they're actually receiving $225 for every patient that was completed rather than the $175. That bonus is paid out in the first quarter of the following year by Excellis and really can have a significant impact on your overall revenue. So some nice extra opportunities here on the financial side. I know that's a lot of information at once, and if we do have time, I'm happy to answer any questions, but my contact information is available and Renee certainly can get you in touch with me. So if there are any questions, don't hesitate to ever reach out. For those established practices, the provider engagement reps that are assigned to you will be looking to have one-on-one meetings to have these conversations and really dive deep into the analytics with you and into your value-based care arrangements to make sure that we're assisting you in the best way that we can. For any practices that aren't yet participating, I'd love to get you connected to our provider network so that they can discuss onboarding. Renee?
All right, thanks, Nicola. I appreciate that.
You're welcome.
I encourage any practice that isn't currently participating in Vatica to reach out to me, and I'll make sure you get the connection. Nicola, I'll be sending these slides out as well with Nicola's contact information, and I'll bottom line it for you in a way that Nicola would probably hesitate to do. Is that from the providers I know who do this, what I'm hearing is that for every chart they're doing, what they're talking about is that, typically a 4 to 5 minute exercise, and they're earning $175 on Excellis members, per chart that they're done. And then they hit that, possibly up to $225 per chart they're finishing if they hit that 65%. So for 4 or 5 minutes work. So I encourage you if you're interested to reach out to me, and I'll connect you to Nicola. So Nicola, if you wouldn't mind stopping your screen share so I can bring mine back up. I would like to move us along now to Christy Howd to talk to us about the new provider engagement report. We've talked about this at practice manager meetings earlier this year. This is a new report that's replacing the AAA report that we think is going to have a lot of improvements, be a lot more dynamic, and with better, more timely data to really provide you actionable data for your providers and help them understand their progress towards incentive based on their quality performance. So with that, I will turn it over to Christy, and I'll advance your slides for you, Christy.
Thank you. Good morning, everyone. So just a quick update for those of you who are new or don't recall the details of this is Renee had summarized. This is an executive summary scorecard that really will show you how the practice and your PCPs are performing on the new reward plan. Now, the reward plan is what will be paid out in 2023 for 2022 performance. So we're in development right now, building the pieces to give you visibility into your data next year so that you have the information you need to make impactful change to increase the performance and maximize the potential reward payments. So there will be links to dashboards that provide additional detail about specific programs that you're participating in and giving you actionable data like patient lists that you can download. And I'm going to show you some example screens shortly. One of the things that's going to be most important to the success of this product is that we get your feedback and feedback from the providers that are using the information. We're developing this, so we have the ability to make changes. This is not a vendor-produced product that we're stuck with. And we really want to make sure that it's information that's useful and that it helps you improve your performance and gives you the information you need and the timeliness that you need it. We're planning to do a demo in the fall clinical grand rounds as sort of our launch. And we're going to be in rollout during October through December, may go into January, February, early next year as well. And during that time, as we bring up your individual practices and work with you, we want to continue to get this feedback. So don't hesitate to share your thoughts, ideas, and just how it's working for you. Next slide. So this is the early design that we've shared previously. It's the landing page that tells you how the practice is doing. We're building Lego pieces that we're putting together. So I don't have the actual landing page yet putting it together, but this is how it's going to lay out, where you're going to get to see the components of the programs and initiatives that your practice is participating in. Everybody's going to see a cost versus quality and how you're doing. We're going to have a quality measure performance section that's reflecting what you're doing with Arcadia, but it actually is a little bit more specific and targeted to information that makes it a little bit easier to get to that information. Depression screening and follow-up, citizenship, readmissions, pharmacy cost reductions, and if it's a pediatric practice and maybe participating in LARC, that would be turned on as well. And there'll be other things that we'll be presenting depending upon, again, the participation in that initiative. Next slide. And then this is an example of what a provider will see. So the first page was at a practice level. This page is at an individual provider's performance, the quality performance for that particular provider, the depression screening and follow-up, the citizenship, the readmission and the pharmacy costs. In all of this, we're trying to put really quick reference here on how are you doing? And you'll see the greens and the blues, trying to make it in simple language. What's the target? And how are you doing? Are you on target? And then you can decide whether to drill in or not. If we wanted to drill into something, we would click into that little double arrow near the top of the blue banner on that component, and it takes you into drill down pages. Next slide. This is an example of the practice cost quality. Now we're still in some testing and data validation, and some of this is still a work in progress, but would love some feedback, whether it's anybody that wants to speak up now or you want to send an email. This will go out in the network news with some links, so you'll have many opportunities to share some of your thoughts. But this is your opportunity to see how your practice is doing with regards to costs. Pharmacy costs is the graph at the top. The black line is how the network as a whole within your specialty. So if you're a pediatric practice, how are other pediatric practices doing? If you are in internal medicine, how are those other practices? So you're comparing it against similar network partners. The green line is an example of how this practice is doing, and their pharmacy spend costs are trending far below the network as a whole. So this is great performance. And then off to the side, we describe the overtime averages and how exactly they're doing. The medical per member per month is similar. This little dip here is again an issue with some data quality that we're working on, but overall the performance is really good. The green line is below the black line, so that this practice looks great. And the very bottom graph is how we are comparing with cost and the quality points. In the past, it's been just performance on quality initiatives. So now you're familiar with the bronze, silver, gold. So you'll see the shading in the graph is indicating the quality performance. And then on the left side is the PMPM costs. And so we have a line across the middle that shows your average, and all the dots are your peers. The big green dot is where you lie within that grid. And this is one that it's in the silver, and it is below average on PMPM. So this is actually pretty good. We're going to continue to work with the practice to move in the quality to the gold area. Next slide. RX Savings is an example of where if you click down into drilling into seeing more of the savings plan, you can see the preferred is the orangish colored line of where the prescribing should be. And the non-preferred are those patients that are potential people that could be switched to a preferred prescription. The potential savings costs by drug class is listed below. So this is an example of the practice has 28 patients on a non-preferred drug. They break down into the classes below, and then there's some cost information there. So if this was a practice that was struggling with pharmacy costs, this gives a lot more detail around maybe areas to target to bring down those costs. And then in the bottom section here, this is actually a downloadable patient list. So of the patient, the 28 that have the potential to be switched to a non-preferred or from a non-preferred to a preferred drug, this is the information. And you can export this out to Excel, and then you have a list that you can go out and can review the charts to see if this is an appropriate switch. Next slide. Nope, back up one. Readmission. So if your practice is participating and has a care manager is participating in the 5 contact readmissions initiative, we want to report to you how you're doing with those contacts. The goal here is to maximize contacts because we believe it has an impact on reducing readmissions. And so contact 3 is really that transitions care contact from the care managers. Over the past 90 days, the little bar at the right shows 56% of the patients have received those contacts. Right now, within the 48 hours after discharge, there's nobody listed that needs a contact. You move down to contact 4, that's the follow-up visit within 7 days. An example, 40% of the patients in the last 90 days have received that contact. And here's a patient list that can be downloaded with information about, what's the risk score for readmission. And you can prioritize and reach out to those individuals to make sure, one, that they have the appointment, but also that they show up. If they don't, you can follow up and try to get that, check in with them and record that activity occurred. Contact 5 is the final contact in around 21 days for those real high risk patients. And this is, again, a downloadable patient list that you can pull off and use to reach out to those individuals. And the final slide is an example of a depression screen and follow-up. And this is one on the right, again, is a list of patients that can be downloaded to Excel and used as a chase list. It'll also be filterable. So overall, your whole patient panel is on the top bar with, this is an example of 854 patients. The green is the screened to date, and the light blue is how many patients have not been in yet for their annual visit. And so there's a couple of baseline lines on the graph. The baseline for 2020 is at the 372 point. And the target is 15% improvement. So this gives an indication that if you get more of those patients that haven't been seen in yet, you can meet that goal for the screening. A little bit more information around the patients that have screened is the second bar. The green represents that 277 patients that had been screened. Of them, 31 are patients that have the positive screening of greater than 9. And the at-risk are 42. So those that have an elevated score, but aren't really in the positive screen area. And the list on the right, the patient list, can be filtered to any of these groups. So if you wanted to check on the patients that say we're in that at-risk area, you could filter on that list, see when their last visit was, when's their next visit, potentially reach out to them. The positive screenings, you want to actually see what's their last visit, when's their next visit, and you can get that patient list as well. And then follow-ups on positive screens, that's really the goal here. So of those 31, how many of them have received the follow-up? And that's the yellow, which is 24, which is great. We want to filter on those 7 that didn't get their follow-ups and reach out to them. You can filter on those and get those in the patient list. So this is, the goal here is to show performance around the expectations of this initiative, and then give you the ability to download patient lists and have outreach as appropriate. And then next steps would be, we really want to get your feedback. So the PowerPoint slides will be shared out. You can take some time to think about the information that we're presenting, what would be more useful to you, and don't hesitate to reach back out and share any of your thoughts. Kevin, do you want to share some of the next steps with regards to our rollout planning?
Yeah, thanks, Christy. It looks really great. I'm Kevin Kelly. I'm supporting Christy in this rollout plan. We are currently in the next few weeks preparing a user list, so be on the lookout for that. And we just ask you to please review that list that we send out with missing information and update us with additional users to include. That's really important. So, and then in September, which next week, wow, expect a calendar invite for individual practice meetings or group meetings. And an email will come with more details about that. But that meeting will be about to identify key stakeholders. We'll go over a setup timeline and how you'll be trained. And then Christy mentioned a demo for the clinical grand rounds, which we're looking forward to. So a lot more to come, and stay tuned. Christy and I are willing to answer any questions now, or I'll put my email in the chat as well. Will care managers be part of that meeting? It's really up to the individual practice, who you want to include on that meeting. And we will send out an email who you want to identify as a key stakeholder in that meeting. Any other questions?
And Kathleen, we do plan to come back to the care management group and do a similar update, so that folks there will have a chance to talk about it as well. All right. Thank you, Renee.
Thank you, Christy. With that, we're going to turn it over to Willie Newdigant to talk about Arcadia, the survey follow-up and upgrade update. So take it away, Willie.
Awesome. So good morning, everybody. So I just wanted to start by building on what Renee said at the start of the meeting about incentive payments. I wanted to recognize the work many of you are doing on the data side to help ensure your PCPs are getting credit for the work they're doing. So I personally want to say thank you for your help. I see that work being done every day, so thank you. So today we wanted to share with you a very high level view of the results of the Arcadia survey that was sent out earlier this year, and the actions taken based on those results. And then I'll touch base on the long-awaited Arcadia upgrade. Next slide. So earlier this year, we had a small group meeting with a number of providers, and they were vocal in their displeasure with Arcadia. Based on that meeting, we decided that we needed to share or see how our community practices felt as a whole. So we sent out a survey to all the practice users who've accessed Arcadia over the past year, asking for your honest opinion. And that's what we got. We received 45 responses from the 27 practices listed here. Next slide. We did receive a number of positive comments about the support you're receiving from AHP, so thank you for those. However, the majority of the comments were a clear sign of the frustration with Arcadia. I didn't want to review all the comments here, it would take way too long. So we can categorize them in these six buckets, if you will. It starts with Arcadia is generally not easy to use. To the various comments about the data. It takes too long for the data to appear in Arcadia. The data is not accurate, which of course then creates the lack of confidence. And if we do find an issue and I submit a ticket into Arcadia, it's taken way too long to resolve that issue. Then lastly, one of the most important points for me is the practices are spending way too much time trying to validate the data. You should be concentrating on patient care and not comparing data from your EMR to Arcadia. Next slide. So what did we do with the feedback y'all gave us? We presented the results and comments in detail to the AHP, AHP leadership, and more importantly, our Arcadia leadership in multiple meetings. Based on those presentations, we continue to hold regular high-level meetings with Arcadia to discuss the issues that led us to this point. I talk to Arcadia multiple times every day about issues that we see and about data validation. And Arcadia has openly admitted to mistakes over the past year and a half around the lack of process, the wrong people maybe in the wrong roles and more. So they're now engaging with HP as process changes are starting to be implemented. And one of those changes is the addition of a customer success manager. This person will be the individual concentrating on AHP and our interactions with them. The most important task, in my opinion, for this person is to track all the tickets we have outstanding with their support team and help push those to timely resolution. So we're not waiting for months to get those resolved. Then lastly, HP is working with Arcadia to be proactive when it comes to data validation. When your practice first initially joined AHP, Arcadia ran what is called a data quality analysis, or a DQA. Part of that report identifies terms from the EMRs that are not being mapped. From that report, Arcadia would correctly map the terms so you get credit for them. And that's the last time it's run for the practice. So now we're working with Arcadia so that HP would be able to run the unmapped terms section of this report on a regular basis, or as needed if we see issues or when the practice upgrades their EMR. So the one thing I ask from you is that let me know if your practice upgrades your EMR. Doesn't matter if the vendor says it's a small upgrade, just let me know. We'll make sure the DQA report is run so we can detect any issues early on. And then, so being proactive with that report should ease the burden of the practice needing to spend a lot of time on validating data. We're not at the point yet where we can run it, but we're working with Arcadia to make that happen. Next slide. So lastly, I want to touch on the current state of Arcadia. We are still using the 2020 measures as we need the upgraded to get the 2021 versions. As it stands today, because of issues they found with their beta customers, the earliest we'll see the upgrade is end of September or early October, which is very frustrating for all of us. When comparing the 2020 HEDIS definitions with the 2021 definitions, there should really only be positive impacts on the performance numbers. However, know that we will be extensively testing the new upgrade in our test environment before we allow Arcadia to move it to a place where you can start using it. In the test environment, we'll be looking at the definition changes and their effect on performance. We will not allow the upgrade to adversely affect provider performance, since that wouldn't be fair since it's so late in the year. As Kevin said, September is next week. Once the upgrade is successfully implemented, the promise from Arcadia is that because of the changes to the software and the back-end processes, the measure definition should be available in the March timeframe moving forward instead of late in the year. Then lastly, one note, we put this in the network news, but just want to make sure everybody was aware. When the 2021 measures are implemented, you will see the depression screen follow-up measure actually split into two. There will be no change in the way the practice needs to record the screenings or the follow-up, but it's just going to make it easier to troubleshoot issues and to see where there are opportunities for improvement. Is it with the screening or the follow-up side? And I'll end by stating what I always say when I meet with you as a group or separately. Do not hesitate to reach out with any questions you have about Measures Arcadia. That's what I'm here for. Any questions?
All right. Thank you, Willie.
Thanks.
I appreciate that. Thank you. Moving on through our agenda, I'm going to, Elizabeth Sharp, our Director of Performance Optimization, wants to briefly talk to you about, give you a little preview of a hypertension toolkit that'll be coming your way. Elizabeth, I'll stop sharing. You're going to put up an image of this document.
I am. First, I'm just going to say hello to everybody. As Renee mentioned, I am in week 2 back from maternity. So this is going to be high level because I'm still touching base with all my teammates to figure out everything that's been done over the summer. But I did want to let everyone know we're going to be talking about hypertensive blood pressure control this fall. The reason that we picked this up in the optimization department is that, well, it's twofold. We haven't traditionally scored top tier on our contracts. So we're usually hovering around the 75th percentile on commercial and Medicare, and 50th on Medicaid. Additionally, one of the focuses that AHP is trying to put a little bit more resourcing towards, I suppose, is looking at equity in healthcare. And we know traditionally hypertensive blood pressure control is an area where racial disparities are very high. And so that's something that we want to make an impact on as well. So this fall, we are looking at possible outreach to patients, likely with a focus on our Medicaid contract. We have created some resources for practices and patients so far. Additionally, we're going to be developing a care management pathway for those patients with extremely high blood pressure. And then longer term, we want to look at those equity issues. As I said, we know that hypertensive blood pressure control is an area where there's been documented racial disparities. We don't yet have great data on race, so we will likely be using our Medicaid contracted lives as a proxy, but we still want to work to address the inequities where we can. So with that in mind, longer term, we're going to be connecting with community resources and building on the work that's already been done. So with that, I am going to share my screen so you can all see what I'm looking at. What we've done so far is put together some resources for our practices. Credit where credit is due. This quality sheet one-pager is the brainchild of Willie, who has really worked to pull things together. I know that Kevin Kelly has also assisted in creating these. And so this is available on our website under our provider resources and then quality measures. And you can see here the description of quality measures. This obviously is the hypertension. We do have other ones available, but as part of our hypertension resources, we have this quality measure definition. The changes here, one of the changes that I really wanted to highlight is blood pressure readings can now be reported or taken by the patient. So this is something that we're not going to be displaying until that upgrade goes through, as Willie just talked about, when we switch over that measure definition. But I'm hoping it's going to be, it's going to give us a positive impact. And as we start to educate patients that this is an option, it's going to be a lot easier for folks to take their blood pressure at home and let their doctor's office know, to go to the Y and stick their arm in the machine. I'm sure there are other places, but I see them at the YMCA when I go, or when I went in the before times. So we have our definition here, sort of any information you might need to know around the quality measure. We have a pharmacy pearl that went out earlier this summer that we are also including in this information. So our pharmacy department put together some wonderful resources around blood pressure management. I'm going to scroll really quickly. This is several pages. I don't mean to make you all sick. We are, as I mentioned, developing a hypertension care management pathway. So we're going to be taking a look with our care managers at those patients with extremely uncontrolled blood pressure, those folks that are very high, maybe have multiple comorbidities, and need something in addition to medication to control the blood pressure, whether that's education, lifestyle changes, additional support. I keep scrolling. We have pulled in some information from the American Heart Association as well. So we have some references for practices around how best to take blood pressure. We know that people do this all the time, so hopefully folks are doing it right. Our executive medical director is not convinced that that's the case, so the refresher never hurts. And then we have some information for our patients. So understanding, I feel like this is a little bit large to be able to actually see here. I'm going to just scroll out a little bit. Understanding what the numbers mean. So we know your numbers, what's high, what's elevated. Are there lifestyle changes that can impact? Some instructions for the patient on how to take their blood pressure so that they're aware whether they're in the doctor's office or at home. And then at the bottom here, we have a blood pressure log. So we're going to be making this available. Stop sharing. We're going to be making this available to everyone. We know that taking blood pressure is nothing new for the practices. It's just something that we want to be able to, sort of bring to the forefront, have folks pay attention to between now and year end. And just wanted to let you all know today that we're going to be hearing more from us about this, both in terms of this toolkit as we sent out, and then some additional resources in terms of potentially patient lists, again, that care management pathway, and longer term, taking a look at the equity issues that we know exist. I feel like I talked really fast. Does anybody have any questions? All right, thanks so much.
Thank you, Elizabeth. Some more to come on hypertension. Quickly, I wanted to talk about COVID resources, just to make folks aware of what is available to you online. And before I show you what's available online, I want to let everyone know we are having a COVID call tomorrow, 12:15. We had moved the cadence to every other week, then we're moving it to monthly. Now I think we're going to be shortening that cadence back to at least every other week, and we'll let you know on tomorrow's call where we've landed on that. The medical center has gone back to 2 times weekly for their COVID command center calls, and that's where a lot of the information that we share with you on those Wednesday calls come from. So since those meetings have resumed, on a twice weekly basis, makes sense for us to shorten the time between our own meetings. So tomorrow, absolutely, there will be a call at 12:15. And I also want to remind folks that a call that kind of grew up from the COVID response, but is now not exactly attached to it, are those behavioral health consult calls that are still taking place on Tuesdays at 12:15. So there'll be one of those calls today with our behavioral health integration team, willing to help, talk to providers about any behavioral health issues they're having with patients. But as far as the COVID resources that are available online, there are really 2 ways to get there. You can click on partner resources on our website, or you can go to the COVID-19 ongoing updates, which, silly me, was getting ready to contact our web vendor to say, oh, take down that little pop-up flag, but I guess we'll leave it up for a while longer since we still do have ongoing updates. When you click on the COVID updates, you're brought to like this landing grid with the various categories of information. So vaccine's been a really popular one, and anything we're getting out of DOH or the Finger Lakes Vaccine Hub is being populated under vaccine. The emails that go out after calls are all archived here. Clinical resources, payer information is one that I do get a lot of calls about. So this is a good warehouse of information that when you do click on payer information, you're brought to another grid that breaks it down by payer. So if you're looking for anything relative to COVID, be they patient resources, clinical resources, payer information, this is a good first stop. If you're having any difficulty navigating it or can't find exactly what it is that you're looking for, obviously always reach out to me and I'll hook you up with whatever we have available to us. So just wanted to share those screenshots with you to make sure you were aware that those resources were available at ahpnetwork.com. I didn't think we have enough time to go on to our next agenda topic, but I think I can get this done in 6 minutes. And I wanted to talk to you about our practice champion pilot that we're hoping to get started soon. And we've talked with this group a little bit about it. And before I tell you what exactly a practice champion is, I want to tell you why it is that we feel we need it just quickly. I mean, obviously COVID has been a real barrier to keeping our providers engaged with what AHP is trying to accomplish. We have a growing number of initiatives. We're always adding stuff to the portfolio of what we're working on. And that's been a challenge as well. We have limited AHP resources, which is no news to anyone, that we run a tight, efficient ship, maybe don't have as many resources as we need, although that's something that we're working on. But the resources available to go out and meet with providers and do a lot of one-on-one engagement just aren't available to us. And then we have those advisory committee meetings with our primary care adults and pediatrics. And there's just a lack of accountability there. People show up for the meeting, they listen, and they go back on with their lives. There's no real accountability to share what they learned with their practice partners. So what we'd like to do is work with practices to identify one person, one clinician in the practice, essentially to take ownership of the practice's relationship with AHP. They're that champion, that person is going to be the one who partners with our optimization team. They're going to partner with the pharmacy team to ensure that what pharmacy is working on is making its way to all the providers in the practice. They're going to work with good care management. They're going to own that relationship. They're going to meet with our pharmacy team and our medical director team to review the provider engagement report to ensure that person is well versed with the entire practice's quality performance. They're going to serve as that general purpose liaison between the practice and AHP. Now, we have other points of contact we always have, right? We have you, the practice managers. We may have an IT contact within your provider. But this champion would be the person to whom we at AHP could possibly escalate things to when we're not hearing back from you, we're not hearing back from your IT champion, or we're having issues moving the ball down the field with your practice, and we need someone who's going to take responsibility to help smooth the way and work with us. This person is going to be the practice's representative to our advisory committees and take responsibility to come back from that meeting and provide a quick punch list of the things that we talked about at that advisory committee meeting that his or her practice partners or the care team should be aware of. So again, it's essentially the person who's going to own the relationship with AHP. Now, what's a champion look like? What are we looking for here? Well, we want a clinician, so MD, DO, NP, or PA, who's in active clinical practice, at least 3/4 of an FTE. We want someone who's really a member of the team, someone who someone who's less than 3/4 of an FTE just wouldn't be in the practice enough to feel to fulfill this role. Someone who cares about what it is AHP is trying to accomplish. They're passionate about value-based care. We're looking for someone who's well respected in the practice, right? Someone, that other providers look to and believe that individual is credible and approachable, and they have the ability to motivate people. Obviously someone with strong communication skills and someone who's very knowledgeable and proficient with your practice's EMR. Those would all be great qualifications for a practice champion. So our next steps in really laying this out, the thing that we're working on right now is a financial compensation proposal. What we're asking for is some time from one individual in that practice, and we believe they deserve compensation for their time. And what that dollar amount should be is what I'm working on right now. We're also developing a model for including hospital employed practices. Our first foray into this will be with our private practices. First, obviously, we want to present to our advisory committees what we came up with on that financial compensation and the proposed model for the hospital employed practices. And we're going to request some applications from select practices in late fall, right? We're going to want a big peds practice and a little peds practice and a big adult practice and a small adult practice, try and see how this will work in a variety of different practice settings. We're going to request from those practices that we select for them to identify an individual that would be a good champion. And then the hope is to implement across the network in 2022. This is just a key strategy to help facilitate all the other work you've heard about today, rolling out the provider engagement report, rolling out the new PCP reward plan, the hypertension work, the depression screening work. We need that individual in the practice who is going to take responsibility for that relationship with AHP, take responsibility to help roll out these initiatives in their respective practices, and bring to it the energy, excitement, and passion for value-based care that the AHP team has, and we know many of our providers and practices have as well. So more to come on that. If you have any ideas about providers in your practice that you think fit the bill, I'd love to hear about them. Feel free to reach out to me, and we'd love to hear from you on this topic. Any questions? I have 1 minute left. Any questions about Practice Champions or anything else you've heard today? No? Okay. So I will end with our usual reminder to remember to make sure everyone on the team knows that your practice is in AHP, and to do your best, especially for our contracted health plan members at U of R, Highland, and Thompson, to refer them to AHP specialists, hospitals, imaging, and labs. And these are our contact list for assistance from our pharmacy team, the Arcadia Help Desk. I got to throw optimization on here, but it's really just Elizabeth's email. But I will add Elizabeth next time. It's 9:30 on the button. Any questions? We thank you for your time today. I'll follow up with the slides, and hopefully we'll see a lot of you on our call tomorrow for a COVID response call. Have a great rest of your day, and thank you for your time today and your attention. Enjoy the rest of your week. Bye-bye.
Thanks, Renee.